So what is quite surprising is that we are in a world where people think there's actually not enough data. So I call this infodemics. So do we need more data? Do we need more data to identify epidemic waves? Let's talk about COVID, where we discovered a lot of data, which is quite spectacular. I think there was a lot of positive effects. So a lot of people started exploiting and using this data. And then when I came here, I thought, well, perhaps I should come up with a new monitoring tool to help us with epidemics such as COVID. So here we have a graph. And you can see that in February 2020, the WHO declared COVID as a global public health emergency. You can see the red lines on the graph show that actually things went down. I'm sure that you know that during 2020, we saw that the number of cases really skyrocketed. And then there was a second wave, which was just as high in France as in Switzerland. Would you like this kind of indicator? We've had some key figures before. I think that this might be interesting. So this is all about surveying and monitoring crises. So in 2019, we had an epidemic, and in 2020, there were about 2 million articles written by a whole range of experts, all about so infectious diseases. A lot of different work was done, a lot of different publications were brought to people's attention. But do we really need more data? How do we process this data? Do we need more articles, more papers, more presentations? And that's the topic of my discussion today. So I'm convinced that we have more and more data. No one is going to deny that. But can we let data speak for itself? I think that some people put forward that idea. I don't think that data can speak for itself. We have to work this data. We have to work on it properly to make sure that it is useful and get key figures out at the end. We don't have the right statistics to help us understand the volume of midwives in hospitals, the number of cesarean sections, then we'll be in trouble. So I'm going to focus on 3 main problems to do with the information about decision-making in public health. I think that people are a little bit confused about what surveillance or monitoring and research really is, and that's what I'm going to be speaking about. Next, infodemic is an issue. I'm not going to go into too much detail about that. And then, of course, the quality of data and the target population. And then I'll bring things to a close, speaking about the idea of going from a big to a slow data culture. My first point is that indeed we do have more and more data. As an epidemiologist, I was trained to focus on data, getting more data about monitoring and inquests and inquiries and surveys, registries, all that kind of thing. In France, you have a very similar culture in this regard to Switzerland. We have more new and big data. People use the phrase big data even in French. It might be a little bit old school these days, but in any case, it's still relevant. So this might come from HCPs, medico-administrative data sources too. So this data might not necessarily be completely 100% linked to healthcare itself, but in any case, it does tie into things quite well. So digital health is a relevant topic too. It's going to be very easy for us to record medical data. So can we let data speak for itself? Perhaps you know this article from Chris Anderson. People were saying that, okay, it was the end of theory, the data deluge makes scientific methods obsolete. So Chris Anderson is not Donald Trump, but he is the chief editor of this publication. This article actually made a huge buzz online. It was very polemic. So 3 problems for public health intelligence. First of all, in my opinion, it seems that we're confusing monitoring and research. So how can we use that to help us make decisions? Because statistically, we might have data which helps us plan out things better, the training courses for doctors, and then research on the other side, which is much more the kind of thing that we are focusing on in other regards. Next, infodemics, and then data quality and target populations. First of all, surveillance and research. So surveillance monitoring, so he means monitoring. So monitoring can really change from one country to the next. Monitoring is done in very different ways. In Canada, I actually did some of my training, and monitoring was used in a different way, if you like. So the true meaning of the word monitoring is that, well, in North America, lots of things have been done very, very well. And historically, they have come up with funds and foundations to oversee monitoring of healthcare data, and they've produced some very encouraging results. So research is all to do with collecting and disseminating data for people who need it. So the example I'll go back to, as I mentioned earlier on, is training. So I need training when I'm doing, I need information, I need big data when I'm doing a training course to become a doctor. And that is incredibly useful for us to then make decisions in public health. One of the issues in public health, and I'm really trying to be careful of this, is that we are very good at this in Switzerland, where we have a lot of public healthcare researchers, but they don't really interact that much with the decision makers, be they in the field where they might be training people or taking care of the system as a whole. But at the same time, with this same data, we can produce the same information. So we might have some knowledge which might be interesting and can be used as a lever for decision-making processes in the future. So this might seem a little bit artificial as a separation between monitoring and research, but as we saw during COVID and the two waves on the graph as you saw, we came up with some knowledge which was produced, which was relatively high quality, but that is debatable. Did it help us with decision-making? Well, that again remains to be seen. It's kind of debatable itself as well. So for different reasons. The thing is, we have two worlds with different cultures. So people do, on the one hand, mostly research, and these people don't necessarily know the actual needs of practices. How do decision makers work? How do they make decisions? And then those who make decisions about populations and policies don't necessarily have a high-level scientific background. The other point, which I think is even more important, and that's the different views to do with uncertainty and errors. And this comes back to the slide I showed. They showed in the previous presentation about the volume of midwives and the rate of cesarean sections. So it was a very nice graph. But if you looked at it in real detail, you would see there's actually a lot of uncertainty. Okay, in a linear perspective, the number of midwives is actually going down. But how are decision makers going to take that into consideration in their decisions? They might seem nice and everything, and having great big data will help us publish more papers and articles, and we're going to be able to resolve this or that problem, whatever. But at the same time, monitoring for decision making can be terrifying. It can actually be a real obstacle for decisions at a high level. So it's a kind of paradox, if you like, where we might publish some data. It is seized on by decision makers, and then will hopefully have a positive effect. We saw previously, well, in any case, when I was a medical student, we decided to limit the number of doctors, given the statistics, which were kind of uncertain, but at the same time, they weren't necessarily at that high quality. It's true that I'm aging these days. I have a few more gray hairs, but at the same time, I think that it's really important for us to have these two elements, the level of uncertainty and the level of error. So next up is the different relationships with health authorities and populations. When we are doing monitoring, we might work in a specific department. And when we're a researcher, we're more in the background, we're more out of the picture, if you like. So it can be difficult for us to not necessarily end up in conflict with them. And at the same time, we might be lacking specific funding. In any case, there are very different fields.
That was the first point. And the second point was I wanted to talk about the infodemic. Here we have this wave of publications that sometimes drowns researchers. It's not really that much of a problem, perhaps. It's only researchers who are drowned, but the quality of research is affected. That's a major problem we're suffering from. I like this other cartoon. This is me when I was training on the left-hand side. One of the first things I did was I did an investigation of the prevalence of high blood pressure amongst children. I did some research. I probably looked at 15 or 20 studies on this, and I was really happy to add my little brick to the building. Now, this is a situation we're completely smothered in information. There's a problem of misinformation or disinformation. I'm not going to talk about that in great deal, though. What I'm more interested in is to talk about this infodemic. We've moved from a classic conventional process. This is how I try to present it, where you have an amount of data, which is processed by experts and people who are familiar with the field, who produce information, and then you get to a decision. That's how I was trained. And I think at the moment we have a slightly different situation now, where we have the number of data sources has multiplied, and this can be interesting and positive from a point of view of thinking about an issue. We're not the only expert who knows what's happening in the healthcare system, and we have lots of people producing information. Data scientists, it goes through the media as well. I used to monitor the COVID situation on the media because their graphs and were much easier to follow than the official health authorities, where their information was difficult to understand. So I got my information more from the media. And there's a social media as well. There's lots of people or entities producing information with different levels of training. We now have a kind of competition in this area of information production, and then this leads on to a decision. So we have all of these elements which make the healthcare information system less efficient. People wondering what we do with all of this information. This is a new challenge we have. The last point is opening the question of data quality and the target population. And then I think we've had a paradigm shift in terms of surveillance. If we come back to this idea I was explaining to you earlier about the data which was clearly defined previously, and now the situation has changed. The conventional approach was to identify a healthcare problem and a system which would enable us to understand the health system. The advantage is that when you identify the health problem, it's often linked to a target population, but often it's linked and it has a certain cost. Now we're in an area where we have big data and in a digital healthcare age. Now we have organic data, we have big data. The problem that these data are not designed to help you solve the problem you have. And another issue is the quality of the data. Either the quality is poor or it's simply unknown, which is a big problem. And also we're not sure about the target population we're talking about here. And that's an important question. Where does this study population come from? Previously we would do a kind of sample, something that would be similar to what we're studying, and then we can do references and say, okay, on the basis of what I studied, these are the conclusions I can draw. Now we have a different system. We have a lot of systems of the population itself is very well defined. It's a question of uses of the healthcare system. It's something that is changing. It's not easy to define. What we observe in this population, how do we apply it to the population we're interested in 4 or 5 years' time? How can we infer what is going to happen? And this is a question of the transportability of the data. One answer is to use slow data. Just to be clear, this isn't a Nordic system to feel happier about data. It's not a call to degrowth public health. Of course not. It's not necessarily cheaper, but perhaps better aligned with the needs of public healthcare and surveillance. It's nothing new, really. The idea is to remind ourselves of this diagram that we have an information system. We need information that is required for healthcare, public healthcare decisions. We can't just stop at the data collection stage. We have to remember this diagram, and the idea is to always be aware of what our information needs are. And also we need to know how we're going to disseminate this information. Whether we use big data or slow data, it doesn't really matter. We have to have data that is the best quality as possible, and we have to be clear about the population groups we're targeting. That's very important, not just work on our data, and we have to work on flexible information systems. I think this is my last slide before I move on to my conclusion. The last point I wanted to make is that we need to have public health institutions that are robust. I think we are increasingly aware of the importance of this, and we have to be careful to make sure that some of our public healthcare institutions have political agendas. Depending on the structure we're in the US, with the healthcare structure, they control information systems, and this is something they're having to deal with at the moment. And we have to be careful with these links with the political questions, and we have to understand that it's important to have the legitimacy to take our decisions, and this slow data needs independent institutions with scientific expertise in these areas, such as epidemiology. There we are. And my take-home message is that we need a change, possibly. I was saying at the beginning, I'm Swiss. We put in place changes in the Swiss way with lots of small steps. The idea is to keep this idea of slow data to improve the efficiency of data-informed and evidence-based public health decision-making. And it's not something that's easy. Thank you very much.